Welcome to a very special edition of Caucus. I'm Steve Adubato. Research shows that there's a strong link between cancer and a person's genetics. Here to explore the ways in which our genetic predisposition can in fact impact the cancer diagnosis and treatment are Dr. Andre Gua, who is chairman of the John Theurer Cancer Center at Hackensack University Medical Center. Dr. Peter Tullius is a professor and executive director of the Institute of Genomic Medicine at UMD&J, New Jersey Medical School. Claire Granger underwent genetic testing to determine her risk of developing cancer, and Milena Subar is vice president and head of Medco's oncology prescription treatment area. I want to thank all of you for joining us. Dr. Gua, let me ask you a question, something we were talking about right before we get on the air. More and more people are getting genetic testing. Why?
Well, there's a great awareness about the fact that some cancers have a genetic risk factors, and in some families a higher incidence of cancer. So a classic question that comes when you first see a patient when you newly diagnose cancer is that, will my kids have it? And then what are the family risk factors? And they always want, obviously to know that. There's actually only a very small subset of cancer so far that we have some genetic screening available that we can do something about it. BRCA1 and BRCA2 is the
Explain that whole BRCA test.
So BRCA1 and BRCA2 is genetic mutations that affect subgroup, ethnic group, and some specific families that have a higher incidence of breast cancer and ovarian cancer. And in women that have these risk factors with a higher incidence again of breast cancer in their family, or male with breast cancer, or certain combination of cancer, breast and GI, prostate, etc., you look for these mutations. And it would help you potentially in family members and siblings recommend some prophylactic measures such as bilateral mastectomy, sometimes also ovariectomy, which is removal of the ovaries, preventive proactively.
Excuse me, you mentioned certain groups. Are there certain ethnic groups that in fact are predisposed to certain cancers?
Correct.
Name them.
Ashkenazi, Eastern Europe Jews with the BRCA1 have a higher incidence of BRCA mutation and a higher incidence of breast cancer and a higher incidence in their families. That's a very classic example.
Some of this is controversial, though, correct, Doctor?
Yeah, it's a very important aspect that you're mentioning. That the discussion is very personalized.
What do you mean personalized?
Personalized, case per case. You have the situation. It's one thing to have BRCA1, BRCA2 mutations, but not necessarily have a very heavy family history of diagnosed cancer. Depending on what age you're diagnosed with a mutation, depending on what kind of monitoring you can do, because it's not like you're not doing anything. You have to be more aware and maybe, as you just mentioned, do surveillance or screening more often. In addition, I think in the future, although we are not there yet, in the future, we will hopefully have early biomarkers, and we'll talk more about
biomarkers.
Those. Biomarkers would be some kind of detectable signature in a peripheral blood, for example, that we hope that moving forward in the future, detect very early cancers before you can diagnose them with imaging and so on and so forth. So it'll be also another way to potentially intervene early. But I think these discussions, as you mentioned, are very controversial. Mostly, I would say it's an evolving field. And as we have better ways to measure these mutations, better ways to make the connection, and what do you do for it? You know, it's one thing to find a mutation. You need to discuss what can you do with it. And as we move forward, we'll find additional markers of these cancers, and hopefully we'll have potentially even a corrective measure that could be a change of behavior. That's also part of personalized medicine, which will become participatory if you have a risk of having X, Y, and Z. So therefore, you try to not have add additional risk factors such as weight and hormone replacement, etc.
Go back to guys again, because there could be a guy in this picture, a husband, absolutely, a significant other, whatever. How prepared are men to be part of such a conversation, Doctor?
That's why I said before, it's a very personalized discussion with case per case with the patient, the family, the caregivers, and the history. Typically in practice, someone comes to see us with breast cancer, and then they have family members that get tested. Well, what we do recommend is to get, for example, bilateral mastectomy. We would tend to do it 5 years earlier than the youngest age of breast cancer in the family.
Oh, so, help me on that. I want to understand that again.
If a woman had breast cancer and she is 45 years old and she's tested positive, and then her two sisters, one of them is BRCA1 mutated, then we'll say, well, if 5 years younger than the time was diagnosed is somewhat empiric. This is to give us a perception of the fact that we don't have a clear answer with that. So we recommend 5 years earlier than the diagnosis was made in the other sister, we should actually do, that's when we should do mastectomy. And depending on where it is in life, it's obviously a very important decision because it has some implication, as we discussed, in terms of fertility, if you do the variectomy, etc. So here comes again in the equation is that we are not, I think it's important to say to our audience that we are not picking either we do the radical thing or we don't do anything. We actually recommend a lot of time to give some time to make the decision to screen on a more frequent basis so we actually are doing something. And then if we see something obviously happening, or if we have, and then as the patient and her family support discuss this and matures with the decision, then over time they become more comfortable.
Do you find yourself trying to help husbands or men understand what they may have a very hard time understanding?
We try as much as possible to explain in later, but I think this is a discussion that really happens mostly within the family and between the spouse and the husband.
I don't want to obsess over this, but I feel like this has got to be happening because if 25, 30, 35, 40-year-old women are doing this, that means many of them will have daughters, and I'm wondering how that is getting dealt with. I'm not saying I know the answer, but I know there's a question out there, and people are looking for advice, doctor.
Yeah, there's no written scenario. Again, depends on the case. We would not recommend and force to obviously test them in the teenagers. And then as you say, the discussion occurs, this is not an emergency. They don't need to have a mastectomy at 16 years old. They don't need to have it at 18 years old either. They just need to be aware. And so as the discussion matures, they see what the patient are going through, the family is going through, then they become sometimes more willing actually and spontaneously saying, you know what, I want to know about it.
Right.
And as you say, the teenagers are very savvy these days, and I think it's important to put in the equation.
Shooting an oncologist, shooting the physicians you're interacting with, I mean, you've
We
got to have access to that, right?
We do have a genetic testing department. Every cancer center, significant cancer center has actually...
At the John Theurer Cancer Center, you have that.
We do have genetic testing, and I want to add one thing, is that genetic testing is very important before, because the families ask again, what should I do and all that, so they go in and try to get informed. But they also go afterwards with the results and then to review, as you mentioned before, all the options. It doesn't mean the sky is falling. Here are the options. And I want to insist again that it's not a black and white decision. It takes time to make those decisions, but there are alternatives to actually be totally radical. I'm obviously not questioning your decision, but to reassure also the audience is that active screening and screening more often is something that's very important.